from my cell.
Good morning, Debbie. This is Taji. Are you able to hear us? Hear me?
Hi, Raji. I can hear you, and I think I heard Lynn a minute ago, so I think we can hear her too.
Perfect. Thank you for doing the mic check for us.
Thank you. I understand the concept of the microphone. It was working.
like to call the meeting to order. Ask the secretary to call roll, please.
Director Garza,
Present.
Director Kim is absent, Director Sorrell, Director Webster Cross, Chair Bott,
Present.
and also remote is Pat Merriweather.
Present.
You have a quorum.
Thank you. I'd like to entertain a motion to allow Director Roll to remotely participate in the voting.
So moved. Second.
Motion been made and seconded. Any further discussion on the motion? Hearing none, then all in favor say aye.
Aye.
All opposed? Ayes have it, motion carries. Thank you. The next regular meeting of the Qualification Safety Committee is scheduled for Friday, January 17th at 9 a.m. Are there any public testimony?
We didn't receive any registrations nor written testimony.
Thank you. Okay, and we'll go to the action item 3A. I'd like to approve appointments, reappointments to Stroger Hospital Division Chair and Department Chair reappointments. Divisional Chair, initial are being presented, reviewed by Dr. Rudy Monclay, Medical Director of Stroger. Good morning.
Good morning, Chair Bart and directors. So I respectfully request the approval of 2 chairs for our Stroger Medical Staff Hospital for a 2-year term running from December 1, 2024 to December 31st, 2026. The first request is for the reappointment of Dr. Fidel Abrego as Chair of the Department of Obstetrics and Gynecology. Dr. Abrego was first appointed into this position in 2020. He's been with our health system since 2003 and had held various leadership roles prior to his confirmation as the Department Chair of Obstetrics and Gynecology. The second request is for an initial appointment of Dr. Perumal Kalyani to the position of Chair of the Division of Nephrology. Dr. Kalyani received her medical education in 1992, which she completed from the Kilpauk Medical College in India. She then came to Stroger Hospital in 1997 and completed her internal medicine residency in 2000. She was selected to be one of 6 chief residents for the 2000 and 2001 year. She then went to pursue a nephrology fellowship at the University of Illinois, which she completed in 2006. She returned to Stroger Hospital in 2009 as an attending physician in the Division of Nephrology. She has subsequently held several leadership roles and was very instrumental in the formation of our, dialysis, building up our dialysis services over here and in Providence. She was then named the medical director of our system's dialysis services in 2021. In July 2023, with ascension of the previous chair, Dr. Peter Hart, to the department chair role, Dr. Kalyani was named an interim chair of the Division of Nephrology. After a national search, she, clearly in my mind should have just been appointed, but we finally confirmed her, so I'm here to seek the approval for her initial appointment to the prestigious position of the chair of the Division of Nephrology.
Thank you. Any questions? I'd like to entertain a motion to approve item 3A, 1 proposed Stroger Hospital Department Chair reappointment, 1 proposed Stroger Hospital Division Chair initial reappointment.
So moved. Second.
Motion's been made and seconded. Any further discussion on the motion? Hearing none, then all in favor say aye.
Aye.
Opposed?
Aye.
All ayes have it, motion carries. Thank you.
Thank you.
We'll move to the EMS report. Thank you so much.
And Chair Bott, for the record, Director Harrington has joined us.
Thank you, Director Harrington. Welcome.
Thank you.
Yes, good morning.
Good morning.
Okay, thank you. I'm presenting to you the report of the EMS Committee of Discharge Medical Staff, a report of credential items. This is staff appointments, reappointments, and changes for the month of December. All right. Thank you. So you have that before you, and if there's any questions, I will be.
Any questions? Entertain a motion to approve item. Well, do we need to have Dr. Allegretti actually first, who's remotely joining us, speak to presenting the Provident Hospital reports and medical staff action items, the committee's consideration. Dr. Allegretti, are you, can you hear us?
Dr. Allegretti? He may have stepped away.
All right. Can I go to the minutes and then come back? Just approve this, Roger.
Well, you could, it has been, both Provident and Sturger has, the appointments have been sent in advance. And I don't have at least a written report update from Provident. So I believe he would just be presenting them for your consideration, the action items.
Well, then I'd like to entertain a motion to approve item 3B, the Sturger Hospital and Provident Hospital medical staff appointments, reappointments, and changes.
I'll make the motion.
Second.
All right, we have, motion has been made and seconded. Any further discussion? Hearing none, all in favor say aye.
Aye.
All
Aye.
opposed? Ayes have it, motion carries. We'll go to our November 14, 2024 minutes. These minutes were approved at the November board meeting, so they're being presented for the committee's review and discussion necessary. Thank you, Dr. Akintoren. I'd like to, any corrections to the minutes from the directors or any questions? I'd like to entertain a motion to accept item 3C in the minutes of the QPS committee meeting of November 14th.
So moved.
Second.
Second.
Motion been made and seconded. Any further discussion on the motion? Hearing none, then all in favor say aye.
Aye.
All
Aye.
opposed say nay. Ayes have it, motion carries. We'll move to now our operational excellence items. No actions needed for these items. They're only being presented for information. So we'll have first updates from the OpEx work groups. And I know that Dr. Rodigan will be joining us, but she's in the ICU today, so we'll make availability for Dr. Rodigan as able to present. So Dr. Jabbar and Diane, good morning. We'll talk about readmissions at Stroger.
Yes. Good morning to the directors. Readmissions continue to do well. We've had our major strategy patient population that we focused on, which constitute correctable and high volume conditions, include CHF, COPD, and our oncology patients for palliative care. So you can go to the next slide, please. For CHF, this group continues to do well. We're in the top 10th percentile, and that's due to focus on making sure patients get into their clinic appointments. We implemented a meds to beds program on one of the cardiac units, which we're hoping to expand very soon. So that has led to, again, this group doing very successfully with this patient population. Next slide, please. For COPD, some of the successes we've had here are we've implemented harmonization of our inhalers for patients in the hospital and outside. as well as we've had a successful effort in increasing smoking cessation efforts in this group to ultimately prevent the exacerbation. We're seeing the number of smokers improve in terms of how many are getting medication replacement therapy. And again, COPD is in the top, it's above the median for readmissions. Next slide.
Dr. Jabbar, before we go on the COPD subgroup A3, there's a tactic barrier identified in January, it looks like, or July, sorry, July. Do you know what that barrier was?
They apply to both CHF and COPD. Previously,
Okay.
we had a transitional care team that were seeing these patients in the hospital and calling them afterward. That team has been shifted in terms of to a different patient population. So we're looking into other staff members taking over some of their roles. So we have, again, just like we've done for CHF, we have meds and delivery to that patient population, and they're hoping to use that same team to take over some of that post-discharge support that our official transition care team is providing.
Thank you.
Are you monitoring how soon they are getting an appointment beyond the 7 days?
Absolutely. So we look at what's our follow-up rate within 7, 14, and 30 days for each of these patient populations. For our CHF, for example, 76% are getting appointments within 14 days of PCP, with PCP or cardiology. So, you know, not for a health system, you know, such as ours, I think that's a pretty good number, but we're certainly trying to improve the 7-day rate, because that's in the 30, 40% range, I think, given month.
Okay, thank you.
Next slide. For oncology, we've had a major push to increase palliative care consultation for these patients. There aren't many things that are proven to reduce readmissions, but this is one of the things that we think can impact that, as well as patient satisfaction. We implemented some EHR tools to support our clinicians in making that referral early in the emergency room and as soon as the patient's on the floor. And we've seen a 50% increase in palliative care consultation. The readmission rate has started to come down. So we were at 21% for oncology, and it's coming down to 18 now, approaching 18.
Great.
Next slide. So this is looking at the whole hospital readmission rate here and to other Illinois health systems, and that continues to go down year over year. Any questions?
Good. Thank you. Any questions here? So the other question I had is, and Dr. Mercadis might be able to comment on this too, is the high reliability conversation we had with Frescini in terms of the training. Suspect that the folks involved in some of this work to reduce readmissions have also been involved in that training.
They have. The leadership team across the system has been engaged in the HRO discussions. And then obviously this work with Dr. Jabbar is Stroger specific, but there's a Venn diagram there that overlaps.
Great.
Thank you.
Director Garza is good? Yeah.
Yes.
All right. I will go to throughput for Stroger Hospital, Dr. Pirco and Peter Sessi.
Good morning, staff and directors. Thank you for the opportunity to present our work. So first of all, I would like to really recognize the work of all the people who were involved in throughput work group over the past year. A lot of good work happened with improvement in majority of our metrics. Our main goal was really to improve our geometric mean length of stay variance, and we approach to this through improving our front end with ED performance metrics, our physician and nursing performance metrics, and our operational throughput, including EVS, transportation, and bed control. Next slide, please. So with regards to our ED throughput, we focused on some changes to implement new Q4 admission model, and also to maintain and further improve our left vote being seen. So I'm very happy to report that our left vote being seen for the month of October was 1%, which is the lowest we ever seen at Cook County, and it's one of the best performance among the nation. We are still working on improving our ED arrival to departure for patients who are discharged. This metric will continue to be monitored and additional tactics will be implemented in 2025. Next slide, please. With regards to our inpatient throughput, our main improvement was to implement Q4 admission model, which really showed how significantly we improved with our length of stay metrics. Our nursing team continued to excel with discharging patients with less than 80 minutes, which is a huge improvement over the past couple of years. There are still opportunities to work on our discharge lounge, which can further improve our throughput metrics, and that will continue on into 2025. Next slide, please. With regard to operational throughput, despite challenges with staffing, our EVS and transportation teams were able to slightly improve and sustain quite good results. Not at goal yet, but heading in the right direction. So hopefully with improved staffing in 2025, we can reach all the predefined goals. Next slide, please. This slide shows our monthly variance to geometric mean length of stay to expected. Our goal was to reach 1.7 days with stretch of 1.2. We were able to go below 1.5 on several occasions during the year. Hopefully this trend will continue moving forward with the new implementation of Q4 admission model. Next slide. I wanted to show a couple additional slides. This is our left without being seen, portraying the lowest performance, the best performance over the past 6 years or so. So kudos to the whole emergency department team for this achievement. Next slide, please. With regards to our length of stay on inpatient units, we can see the dark green line shows 2024, and we can see how significantly we have reduced comparing to the first month of 2024, and the trend continues with reduced length of stay moving forward. Next slide, please. This slide portrays only medicine units. Our most interventions were focused on improving length of stay on general medicine wards. And as we implemented our geographical localization changes at the end of August, we can see significant downtrend, and hopefully that will continue in the coming months as well. Next slide. And that's all we have. And I would like to also thank Dr. Sessi for being my partner over the past year, and I'm open for any questions. Thank you.
Thank you, Dr. Pircon, Dr. Sessi. Any questions from the directors? Okay. Well, one, just thank you for this report and just express our appreciation to the team for the hard work to get to these outcomes. One of the questions we can talk about, and maybe in the next meeting, is just some of the variation on the GMLOs expected, where I think in May was low, then went up in June, and then trended back down, but why that variation may occur. Good. But there are no questions, comments from the directors. Thank you.
Thank you.
Thank you.
So Dr. Radigan, I believe, is here, so we'll jump to talk about clinical outcomes at Stroger Hospital and come back to the other section. Dr. Radigan and Heather, thank you. Good morning.
Good morning. Good morning. Thank you so much for the opportunity to present. As you know, we're the clinical outcomes team, and we'll be talking to you about our 2024 goals and updating you. As you can see from the slides here, we had two major goals for clinical outcomes: to reduce the number of hospital-acquired infections. As for our central line-associated bloodstream infections, our goal was a SIR rate less than 0.8. Also, our catheter-associated urinary tract infections was also a goal SIR rate of less than 0.8. Heather's going to take the next slide to talk about this in more detail, but as you can see, we really concentrating on ensuring that our nurses were compliant with CLADI and CLABSI bundles, and then really ensured that each line and each catheter in the hospital was accounted for. What that means is that we know every patient that has a central line, every patient that has a Foley, and we know that those actual Foleys and central lines are needed. In terms of our second goal, it was to reduce the PSI 12, that's post-operative PE and DVT. We're going to go through these goals in more detail later on in the presentation, but really we worked on education, ensuring we had optimal heparin and SCD usage, and then really working on ensuring that VTE prevention was part of our daily rounds and a part of a visible area within each area of the hospital. And we'll talk about that more later on in the presentation. Heather?
Next slide, please. Thank you for giving us the opportunity to present today. In this slide here, this is the A3 reporting tool that is showcasing the nursing and physician efforts for the hospital-acquired infections, specifically the CLABSI CAUTI, which you can see the goals to the left there. Those specific action items and tactics are listed in this A3, specifically central line-associated bloodstream infections and catheter-associated urinary tract infections. Our nursing and physician partners have successfully executed all of those tactics and action items in the last 10 months, as you can see as it is represented in green there up until October. And Dr. Radigan is going to speak specifically regarding the monitoring performance in the next slide.
So this is our performance monitoring for central line-associated bloodstream infections. As you can see, our SIR goal was less than 0.8, and we're currently at 0.78, so well below our goal and doing quite well. Next slide. As for catheter-associated urinary tract infections, our SIR goal was less than 0.8, and as you can see, we're currently at 0.67, so well below our goal. Next slide. As for our post-operative PE and DVT PSI 12, our goal was quite robust. Our goal was less than 7. That was a 50% reduction, and currently we're at 11. Next slide. When we noticed mid-year that this was increasing more than our goal, what we decided to do is actually take additional tactics in order to make sure that we optimize those numbers as much as possible. So I'd like to just take a moment and highlight the areas that we've really been working on for the last few months. And I think we're going to see drastic improvement in 2025. As you can see, our number one goal is to optimize timing and accuracy of VTE abstraction. What that means now is that for all of our PSIs, we actually have a PSI map to ensure that we're doing these abstractions as accurately and fast as possible, so we know exactly what's going on with every single PSI 12. And then obviously hospital-wide education. This is for residents and attendings and nurses, and really just changing the culture of Cook County Health. And then what that means is really having direct visualization of the VTE status and communication during interdisciplinary rounds of the VTE advisor and risk assessment. So what we're going to be having in January 2025 is a spot on the teletracker, so we know the VTE status of every patient on the ward, and then daily emails really announcing exactly which patients may be missing VTE prophylaxis, and then develop a culture of VTE discussion in interdisciplinary rounds. So not only do we talk about whether a patient has a Foley or central line, but also whether the patient actually has appropriate and optimal VTE prophylaxis. And then really we had a huge push towards optimizing SCDs post-operatively. This has a lot to do with our nurse leadership in terms of really ensuring that we can have as optimal use of these SCDs, and then really ensuring that we have the best SCD inventory. We've been working with Dan Ruiz to ensure that all SCDs are accounted for, that we know which ones don't have RFID tags, which ones have dead batteries, and then really creating a VTE celebratory campaign and really celebrating those nurses and our all-around staff that are able to find more SCDs within the hospital and ensuring that we have adequate supply for our patients. Any questions?
Any questions from directors? No. Thank you for that report, in particular. The one question I have is that who was doing the VTE abstraction?
So we have Dr. Amra Misra, So she's doing, we have a complete, and we can always show that to you, we have a PSI mapping that occurs so that we know every single case. If there's any question, there's a direct accounting of who it goes to. If there's any discussion that needs to had, or we have to ask for input from the physicians, that happens immediately. If that doesn't happen immediately, it's escalated, and then it goes through the process to ensure that coding is optimal also.
Great. Director Garza, anything from you? All right. Well, I appreciate the leadership and our best and appreciation to the team.
Thank you very much.
Thank you.
Thank you. We will now go to clinical outcomes for Provident Hospitals. Dr. Loafman, Rafael Rayo.
Good morning. Rafael Parao, Director of Nursing Operations for Provident Hospital. Thank you for the opportunity for us to share our clinical outcomes work group. Our first work group is the two are sepsis bundle protocol and for hand hygiene. As you can see, all of our tactics have been green for the year. Next slide. For the sepsis work group, most of the tactics are done. I want to thank the quality team, especially Iris Esquivel for gathering our data, and Dr. Hussein, who looks through the data to see which cases count. The two yellows to ensure the Tiger Connect roles are active for all deep beds. That is actually green now. And then our biggest obstacle still is leveraging the technology to pull the vitals into the EMR. A lot of that is more education for the clinical team and also accountability for those fallouts. Next slide. For our hand hygiene, we have had 300 observations every month for the past year. It started last October, and that was the biggest obstacle, was actually getting the observations to see what our raw number is. Dr. Loafman helped tremendously with bringing it to the QPI meeting, and also we now have hand hygiene champions for most of our departments. So that has been a big help. Next slide. We can go through our numbers. So for our goal for the sepsis 1 bundle compliance is 60% with a stretch goal of 65. As you can see for, I believe that should be, I can't see, last month, we were at 66%, 2 out of 3. We did meet our goal and our stretch goal. We just have to be very careful because our N number is very low at Providence, so we just want to make sure that every single case we do our best. We are leaving this on for 2025 because for our rolling 12, we're not meeting our goal or our stretch goal, so we really want to see what else we can do to help this. Next slide. And for hand hygiene, as you can see last year in November, we took a little bit of a drop. That's because we added more observations. And when you see more observations, you kind of get a better number on our compliance. And with all the education that we provided and the consistent observations monthly, you see the trend line going up there. And for last month, we were at 92%, which passed our goal of 80% and our stretch goal of 90%. So not only are we compliant with our observations, but also our hand hygiene compliance. I think that's all I have. Any questions?
Excellent work on being able to work on the handful.
Yeah, I think the biggest thing is when throughout the process, when we identified different departments that were not as compliant, I would reach out to those departments for a hand hygiene champion, and it's a lot easier to hold your peers accountable than just someone from leadership.
And remember the celebratory process in that as well too,
Yes.
for them reaching that stretch goal. Is there any additional support that you need for the AI leveraging technology? That seems like that's been an
No, we have the capability. Our monitors can pull automatically into the EMR. It's just, again, holding the team accountable to in that process.
And then on, there isn't, I guess, to your point about observations on the sepsis 1 bundle compliance, SEP 1 bundle compliance.
I'm sorry, say that one more time.
The monthly SEP 1 bundle compliance shows 0.
Yeah, some of those are actually 0 cases.
Okay.
Again, like our N number is really low. Sometimes our highest is 3 cases, and then some months we actually don't have a sepsis case or one that meets the criteria.
Thank you.
Thank you.
Thank you for the work on this. I'll go to HEDIS Health Registries, ACHN with Dr. Arns and Ida Guerrari and Elizabeth. Yeah.
Good morning.
Good morning.
Thank you for giving us the opportunity to speak on our HEDIS data. What you're looking at is our overall work group strategic A3. We basically chose 2 specific measures to track, and those measures are blood pressure control as well as pap smear in our women 21 to 65 years of age. For those specific action or tactics that we developed for those 2 measures, first one for hypertension, we had chosen to ensure that everybody has equipment that they need to be able to perform their job effectively. We are happy that we're able to get them those equipment supply. Secondly, we are in the middle of developing a robust staff-supported hypertension protocol. We're still working on that. Hopefully, by the beginning of next year, we should have that ready. For the pap smear, we also developed audit tools as well as ensure that our providers are spreading positive messages, good messages, evidence-based messages from other clinics to other sites as well. Those were the areas that we felt we could work on. My colleagues will talk a little bit about the subgroup A3 now.
All right, next slide. Good morning, everybody. Beth Baklovic. So specifically to the hypertension management protocol, the protocol that we've been working on is going to have, as Dr. Adio said, a robust approach where patients who have hypertension will be scheduled with care management visits, so they'll be seen more frequently. It allows for dose escalations and algorithms for more frequent visits and a connection to the clinic on an ongoing basis. So by the time that they have their return appointment with their provider, their blood pressure should be down and should be well managed. That protocol underwent several revisions, and it is now in the final approval process with the committee. So we expect that to roll out, as Dr. Adio said, early in 2025. The equipment is on hand and on site. And then the training around that protocol and the comfort level with the ordering of the protocol is what we'll be working on probably in January. Next slide. Specifically to the cervical cancer screening group. So there's been some education for the staff on cervical cancer screening, the need for cervical cancer screening and how pap smears can save lives. We recognize that pap smears help save lives by catching cervical cancer early and making it more treatable. So our approach has been, because this is something that's happening in all of our clinics, we are doing small tests of change. We started off with looking at what is the pap smear setup, educating the entire team so that they know how to set up the room appropriately, making sure that there was sufficient equipment, and then providing that education in skills days. So every year, the staff will go through a renewal education of setting the rooms up for pap smears. We then focused in our GMC population with a nurse clinician, where there was education of the medical assistants and nurses on the room setup. There was daily audits of those rooms before the patient went in, and in the chart and discussion with those medical assistants and nurses. That has gone well. Those audits have been very good, and now we are looking at the rollout to the other units for the same process. So we want to make sure we can cascade that information and have the same success in our other clinics. Next slide.
Thank you very much, Dr. Pett. What you're looking at is our performance monitoring data for the last, rolling data for the last 12 months. As you can see, we actually achieved our goal. We dropped a little bit towards the end of the year. We believe that the things that we have in place, specifically the protocol that we are developing, will probably help to address that. We're also looking for more robust workflow for each of our clinics to ensure that we are adhering to the policies that we have in place for blood pressure monitoring. We reset our goals for the next year. We're actually going to push it up to about 57%, and then we have our stretch goal about 61%. That will push us hard to at least get to our set goal for 2025. Next slide, please. Same thing for the pap smear. We actually achieved our set goal as well at 47%. Our top score was there about in October, where we are about almost 48%. We never got to our stretch goal. We believe that the things that we have in place, especially PAC audit kit that we have in place and the robust workflow that we are developing, will also help us achieve in 2025. Thank you.
Thank you. Any questions from directors? What are some of the barriers you're seeing on the cervical cancer issue?
Yeah, the biggest thing we have is documentation of external pap smear. We need a better tool of actually picking up those external pap smear documentation. We want to take a lot of responsibility away from the providers. Currently, we are doing it manually. If we have tools in place, clinical support decision tools that we believe can help us to do this better, and then we'll be able to pick up on those.
Thank you. All right. If there are no other questions, comments, thank you for sharing this information at work. Good to see the progress. All right. Now move to the OpEx dashboard, and I think Raji will join us remotely. Raji, are you there?
Good morning, directors. Yes,
morning.
I am here. Thank you for allowing Ling and me to join remotely from the IHI Forum in Orlando. We are very proud to be presenting on behalf of CCH on two topics that we know the board will be very pleased to hear about. One of these posters actually highlights the engagement of our general board as well as the QPS board. There was a study that came out from American Hospital Association in 2022 that mentioned that even though 50% of the boards rate quality of care among their top priorities, 37% failed to include quality performance reviews on their agendas. And the report also mentioned that 58% of the board dedicate less than 20% of their time to quality, despite the accountability for patient safety and quality falling heavily, within their purview. So we are really fortunate to have a board here that's very engaged. So I want to take this moment to thank you all for being so engaged and also for holding us accountable for the metrics we set and the goals we set to accomplish every year. We also have another poster that was accepted that highlights several efforts that Ling had implemented, for employee wellness and engagement. I don't want to steal her thunder, but I also wanted to make sure that I know that that's a topic that's very close to the board's, high on your priority. Since most of the teams for the Stroger work streams have presented, if I could keep it really high level, I would appreciate that. I understand the patient experience team did not get to present this month. So if I can highlight patient experience and just really go through the rest of the report really quickly, if board is okay with that, I can do that.
Thank you.
All right.
Yes.
Yeah.
And
all
just,
right.
Want to say congrats on the recognition for Cook County Health to be represented at IHI. That's excellent.
Thank you. Dr. Kurt, that was writing up the poster was the easy part. So you all are doing the hard work for us. So thank you. All right. So for the patient experience work group, the percent top box for communication with nursing has been trending above the baseline and has been performing really strongly for the monthly percent top box for the past several months. Moving on to the survey response rate metric, we anticipate that with the new CMS rule that allows us to send electronic surveys in addition to the snail mail, we hope to start seeing this number improve significantly next year. Starting in January, both Stroger and Provident will start sending emails to supplement the regular snail mails. Link's team is exploring additional ways to reach a broader base, while staying within the constraints that CMS, has, set up in terms of, how we can reach out to the patient. So, however, with all the new additional venues, we are allowed to use in 2025, we are pretty certain that this number will be going up. The team for clinical outcomes is already presented on their tactics and their metrics. So if it is okay, we can really, keep it really high level. For CLAPSI, we have seen so far, year to date, we are seeing a 6.6% reduction. For COTI, there was an uptick that the team has already mentioned, and their mitigation strategies related to that. In terms of VTE, we are actually seeing a 15% reduction compared to our performance in 2023. Moving on to the readmissions groups work, the metrics is, both metrics, monthly as well as rolling metrics, are looking really good. And I know the team, just completed their presentation. So I will move on to the GMS LOS variance in days, which the team presented on their, quick pivot through the year, halfway through the year, when they noted that there was an up, when they noted that the metric was trending in the wrong direction, which has helped us to get that metric to our, historic performance right now at 1.6%. So kudos to the team. Can we move on to the next slide? And the next slide. All right, thank you. Here for patient experience for Provident, the data has been trending inconsistently for the past several months when it comes to monthly percent top box. And the survey response rate, again, it is starting to look it's starting to look, like it's in the green. It's above our bench, above our target goal. The sepsis bundle compliance data looks good. Again, as Raf was explaining, because of the low numbers of sepsis patients we see at Provident, there is some variability, that we see there. However, this will continue to be a goal for the team next year. In relation to the left without being seen goal, the team has done a phenomenal job. So if you look at the data from December of 2023, where we were at 11.5%, now we are down to 1.1%, which is a great accomplishment, which is truly worth highlighting at many national forums. All right, moving on to the next slide. And the next slide. There you go. For ACHN, again, the performance related to consent for nurses assisting with the problem resolution has been trending really good above our target goal. On the same metric for the monthly performance, the team has been performing above their target. Related to the provider explaining the problems and conditions, that has been trending in the right direction for several months. The team is looking to really take it to the next level in 2025. We will be presenting the tactics and the goals for 2025 shortly in the next meeting. Moving on to the courtesy of registration staff, that's an internal metric, not a CMS metric. The team, that metric has been trending really favorably for the past several months. Moving on to the HEDIS measures, since the team has done a wonderful job of presenting, if it is okay, I will move on to the next slide. I think that's the last slide, Debbie. As I mentioned, the work groups are currently in the process of finalizing their goals and tactics for 2025.
Raji, are you there? Did I lose you?
Yeah.
Okay.
Can you hear us,
We can hear you
Raji?
now.
Okay, can you, all right, sorry about that. Can you hear me okay now?
Yeah.
Okay. I was saying that the work groups have finalized their goals and tactics for 2025. Each work stream and the work groups have identified their dial leaders as well as the executive sponsors. They're just fine-tuning the tactics for the subgroups at this point. We will plan to share the final sets of goals and tactics with the board in the next committee meeting in January. With that, I will conclude my report, and I would be happy to take any questions.
Any questions, comments from directors?
Raji, thank you for this information. One question, I noticed we've had
Director,
some.
can you speak to, she can't hear you if you're.
Oh, there you go.
Yeah.
All right, sorry. Can you hear me now? Raji, thanks
I
for
hear.
the work and congratulations on these excellent scores. We have had some information that there have been several pharmacy closures, particularly on the south side, as well as some grocery store closures, which unfortunately will affect not only patients' abilities to fill their prescriptions, but part of the patient experience. Have you had or any reports on that, or is that something that we follow as part of the patient experience indicators? Because they certainly can have ramifications not only on health, but also with being able to access groceries, et cetera, will then potentially impact our hypertension scores and as well too if they're not able to access food. But I know that there have been several closures this quarter in both ways that we've noted.
Director Sora, that is a great question. I have not been informed of any impact on our inpatient side. However, since your question was more focused on the community side, if the HEDIS team is still in the room, can either Dr. Irons or Beth speak to your understanding of the impact it has on our patient population?
Right. Thanks. And I wasn't sure exactly where that parameter or benchmark lay, but that certainly will affect our patient experience and their ability to be adherent with their regimens and follow up. So social determinants of health are once again coming into play.
Yeah, it's not something that we would get necessarily direct feedback. It'd be more anecdotal from the patients coming back to say, hey, we lost access, this is where I went. I will say at like Blue Island, we do have an open pharmacy there. So, I mean, we are able to kind of within CCH potentially take some of that on. Again, it's not something that we were really made aware of in terms of the closures, but, yeah, it's something we'll have to look at.
Thanks.
Yeah, Director Sorrell, we will continue to monitor. I will connect with our ambulatory team as well as Link's team to make sure that we escalate and, we come up with a plan if it is looking like it's impacting our patient population. Thank you for letting us know.
Any other questions? No. Raji, it'd be great to, for our next meeting, also hear some of the insights from the Institute for Healthcare Improvement meeting of how those might be applied to our health system in terms of, alignment with the plan for quality and patient safety in 2025.
We'll be happy to oblige. Thank you.
Thank you. Thanks for the good work and the progress. All right, so we'll go on to the regulatory and accreditation updates, which Raji, I think you're slated to provide. And then we'll go to the report with Linda, our Chief Experience Officer. Raji, you there?
Yes, that would be me. I am so sorry. I was trying to pull up the report. Sorry about that. So yes, in November, Stroger ED had successfully completed the Emergency Department Approved for Pediatrics or EDAP survey by IDPH. We are awaiting the final report from the surveyor team. However, the surveys were highly complimentary of the ED team during their closeout session. So we are anticipating a favorable report. We hosted another IDPH team here for an unannounced survey at the same time as the EDAP survey. The focus of the unannounced surveys was more on the EMTALA services side. The survey went generally well, and the regulatory team currently is in the process of submitting a response in collaboration with Stroger leadership and Stroger ED team to IDPH in response to the findings from that survey. The Stroger lab had successfully submitted their response to the College of American Pathologists, or CAP survey, that was completed in October and has since received the accreditation letter for the point of care program. We are expecting to receive accreditation letters for other lab programs in the next few weeks. We are continuing to monitor the measures of success related to the triennial survey findings, and the departments are now reporting out on their metrics related to those findings through the quality committees. We are also in the window survey for a few surveys, that are coming up shortly. One of those surveys would be dialysis survey that is expected to be completed before the end of this month. And we are also expecting primary stroke certification survey from the Joint Commission to be on site before the end of April. We are also in the process of submitting our application to be surveyed on for health equity certification from the Joint Commission for the very first time. We expect an on-site evaluation by the end of the first quarter. I want to also take a moment to introduce to the board our new Director of Regulatory Affairs and Accreditation, Joseph Capenas. Joseph, I'm very sorry I'm not there in person, so I couldn't really, introduce you to the board in person. So if you are in the room, if you can please stand up for the board, I would appreciate. Board, I am very pleased to share with you all that Joseph comes to us with an impressive background in the regulatory field, and we are excited to welcome Joseph to the quality team. So moving forward, Joseph will be presenting on regulatory affairs. So thank you. That's the end of my report.
Thank you, Raji, and welcome, Joseph. We look forward to working with you. All right. Thank you, Raji. Any questions from directors? All right. We'll go to our quarterly grievance report reviewed by Lynn Dang.
Thank you.
Joining us remotely.
Thank you, Lynn.
Yeah.
Yes. Can you hear me?
Yeah, can hear you. Can you hear us?
Yes. Thank you so much.
Great.
Lynn Dang, Chief Experience Officer, and I guess we're waiting on the PowerPoint being pulled up.
Yeah.
So as we wait, I just want to specify that starting fall 2025, CMS will require us to track and report our grievance resolution performance to our governing board quarterly. We want to be proactive and start reporting the data now. So with this slide, this is the report of all the cases. As you notice, the complaint and grievance cases are down. This progress could be a direct link to our team's focus on real-time service recovery, which has enabled our staff to address concerns effectively at the point of care. By resolving issues promptly, we have successfully minimized the need to resolve or involve patient relations. Next slide, please. Here we have the report broken down by facility and by month. Given the scale and volume of operations at Stroger, it is expected that the majority of the cases originate from this location, as it serves the highest patient throughput within our network. Next slide, please. Here is another perspective on the data, highlighting a positive trend. Our complaints and grievances are steadily decreasing. Again, this improvement reflects on our proactive efforts, particularly in equipping the managers with real-time training to address issues as they arise. Next slide, please. So we have the top most frequently reported issues parking concerns, in particular, often stem from individuals seeking assistance from patient relations after losing their parking ticket. And as you notice at the bottom, there are we have the touch points. These refer to complaints or grievances that involve various aspects of the patient experience, such as a combination of either quality and care, accommodation, access, and or response time. Next slide, please.
Lynn, could you just say more about access, what it means in this context here?
Sometimes the patients have frustration when they call to try to make an appointment or to get referrals. And so that's the access, when they feel like they're having such a hard time being able to reach someone. And we are working on the, it's not AI, but more of the call center to try to provide easier access for our patient when they call our 800 number to reach somebody. But we know that that's an opportunity for us, but access is one of an issue that the patients would have. Yes. Does that answer your question?
Yep, thanks. I know, just we have some new members of the committee, so
thank you. Thank you. So here is the breakdown of the top 5 categories for grievances. Behavior and respect have emerged as the most reported grievance category, highlighting an important opportunity for growth here. We know this underscores the need to strengthen our culture of empathy and patient-centered care, and we are actively addressing this through our CI Care training, which emphasizes on communication, conflict resolution, and respect. Next slide, please. This analysis is based solely on grievances, as CMS mandates that grievance cases be closed within 30 days and acknowledgement letters be sent within 7 days. I'm pleased to report that we have achieved 100% compliance in sending acknowledgement letters within the required 7 days, and we are maintaining the approximately about 90% compliance in closing cases within 30 days. And it also reflects our dedication to meeting regulatory standards and improving our grievance resolution process. Next slide, please. Here are the demographics of the patients we serve at Cook County. 44% are Black Americans and 35% white, with the remaining portion representing other ethnicities. This diverse population underscores that we ensure equitable access to care and serve the needs of our community members. And next slide. Since the board has frequently asked about our customer service training, I'd like to share the patient feedback from 2021 before we implemented our standards of behavior training compared to now. While we've seen a 10% improvement in positive feedback, there is still room for growth. This presents an opportunity for us to continue to refine our approach and further enhance the patient experience moving forward. But I'm proud that our positive feedback has improved by 10%, which is significant. Next slide. So I'm not going to read through the next 4 pages, but I'd like to take this opportunity to highlight some of the wonderful feedback we have received from our patients. They consistently praise our staff, doctors, and nurses for their dedication, compassion, and exceptional care. It's clear that the hard work and commitment of our team are making a significant positive impact on the patient experience, and I'm proud to share this recognition of their efforts. And I hope you have the time to actually read through some of the amazing comments that the patients are saying. So we could skip through the rest of the slides, and the last slide is I just want to thank you for your attention and your continuous support. And it's evident that IHI accepted our a board engagement poster, and it's due to you and the leadership of Dr. Makaitis. So I welcome any questions or comments you may have. Thank you.
I have a question on the demographics.
Yes.
In terms of the age, it's the cutoff is 64. I assume we see patients beyond the age of 64.
Yes, we do. I just wasn't able to take a screenshot of it. So age 65 and up, we actually have had 241,801 visits. So that's 23% of our population.
Okay, so the largest population we see are people 55 and older.
Yes.
And there's a drop off after 18, people less than 18 years old, it drops down to 4%.
Is it 4 or 6%?
18 or less is 6%.
Yes. Mm-hmm.
18 to 24 is 4%. There's a drop off. I mean, so it implies that people between the age of 18 to 24 are less likely to come in for an exam, which
Yeah, it's population-wise, right? No,
Right.
But they just don't engage in care as much.
yeah, right.
Yeah, they are.
But
They're
it's
more right.
an interesting observation.
Yeah.
And I remember being 18 to 24, and I was very healthy and unlikely to see a doctor.
You're invincible at that age. Yeah.
And some of the breakdown with the HCN versus the hospital environment, some of there are differences there probably as well.
It's a good point, Director, though that's the best time to be able to help engage people in recognizing that those yearly checkups, HPV, other types of things that we can do preventative.
They're still important.
Exactly. So methods to be able to try to encourage that group to engage would be a great effort.
That's a great idea. We'll look into that. Thank you.
Thank you, Director. Any other questions, comments from directors? All right. Well, thank you for the good work and continued progress. So now the committee will go into closed session. Actions not anticipated to be taken in open session after a closed meeting is adjourned. So we need to proceed to motion, go into closed meeting. So
I'll make the motion.
I'd like to entertain a motion to go into closed meeting pursuant to the following exceptions to the Open Meetings Act, 5 ILCS 120/2, 111/1217.
So moved.
Second.
Motion's been made and seconded. Is there any discussion on the motion? Hearing none, then Madam Secretary, please take the roll call vote on the
Roll
motion.
call vote on the motion to go into closed session, aye or nay. Director Garza?
Aye.
Director Kim is absent. Director Sorrell?
Aye.
Director Webster Cross?
Aye.
And Chair Bott?
Aye.
You have 4 yeas and 1 absent.
Ayes have it, the motion carries. We'll now go into closed meeting. So if members of the public can